Hi, my name is Brooke Babin. I am a nurse practitioner student at Clarkson College, and I will be going over prostate cancer guidelines in primary care. As primary care providers, we learn that when we take on a new patient, we'd have to do a thorough H&P, history and physical. With prostate cancer, it is most of the time genetic. So when we are taking that family history, that becomes very important for us because this helps us determine the populations at risk. So age 50 for men at average risk, and these are men that don't have a family history of prostate cancer and are expected to live at least 10 years or more. And then we go on to a higher risk of men that are age 45 and older, such as African Americans and men who have first-degree relatives with prostate cancer diagnosed younger than 65. For example, my father, his father, and his paternal grandfather all had prostate cancer, and his father and paternal grandfather both died from it. So he would be at high risk. He would not be in the next category, the higher risk, because it was just his father that had prostate cancer, not, let's say, his brother. So then we move on to age 40 for men at even higher risk, and those with more than one first-degree relative who had prostate cancer at an early age. There are many different types of ways to test for prostate cancer. The least invasive first-line test that we can use is the PSA, or prostate-specific antigen blood test. So PSA, it'll test for cells in the prostate, and these cells are mostly found in semen, small amounts in the blood, and we want these levels to be lower than 4 nanogram per milliliter. And these are usually safe levels. And if they're any higher than that, we should be suspicious and probably move on to a prostate exam. Men with a range between 4 and 10 have a 25% chance of having prostate cancer. And this is according to American Cancer Society guidelines. Some doctors or urologists, this varies, and they have different ranges that they like to go off of, but for right now we'll just go with the ACS. So if us as primary care providers do a PSA test that's greater than 10, this usually tells us that the man has a 50% chance of having prostate cancer. If the PSA levels are of concerning levels or concerning ranges, then we're going to move on to the digital rectal exam, or DRE for short. The first thing you want to do, practitioner usually wants to lubricate the index finger or whatever finger that would be best. This test is usually uncomfortable, but it should not be painful. And it should, once the digit is inserted, it's maybe possible to feel bumps or lumps or kind of hardened areas on the prostate, and this usually means that it's cancerous. The DRE is less reliable than the PSA test, but sometimes you can find the presence of cancer with a digital rectal exam and have a normal PSA level. So it's good to do both if you're comfortable. I just have an image of the male anatomy, and you can just see the prostate. You can see the seminal vesicles, the urethra. They both travel and bifurcate through the prostate. If you look on the posterior aspect of the body, the rectum, once the finger is inserted, you can usually feel the back of the prostate there. And in most cases, we'll continue on. If screening results are abnormal, we can always retest. There's no issue with that. Or we can do more specialized PSA testing, and I'll list those later on. If the patient's very concerned, we can also obtain a prostate biopsy. If this becomes out of the realm that we're comfortable with, we can always have them follow up with a urologist, especially if they have a family history, their PSA levels are high, and we do feel, some kind of lump in the prostate with a DRE. The other PSA tests that we could perform are the prostate health index, the 4K score, the percent-free PSA, or the XO diagnostic prostate test. And we could also do an MRI, so imaging of the prostate to diagnose and stage. If your patient wishes, it might be appropriate to obtain a prostate biopsy, especially if everything indicates that. And that follows up with a core needle inserted up into the anus through the perineal wall into the prostate, and cells are removed and sent to pathology. Then they can stage it and let the patient know how aggressive the cancer type. So men, according to follow-up for us as primary care providers, men who have a PSA of less than 2.5, they should just be retested every 2 years. And if screening and the patient is over 2.5 and less than 10, we should screen them every year. And if men who have less than 10 years to live, we should not screen them. It doesn't really benefit them much, just because prostate cancer is usually slow growing in this patient population. And my references were from the American Cancer Society only, and I appreciate you watching.